Yes, in today's class, let us try to discuss about Melphalan. This drug is very, very important. Everybody try to remember Melphalan. Melphalan, the drug, it is starting with M, right? And this Melphalan is very, very effective for multiple myeloma. Just remember triple M, 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 like WWW. We have M, M, M. Always remember triple M. First M indicates Melphalan, and this Melphalan is very, very effective. It is commonly used for multiple myeloma. Okay, so this is very important point. First point you have to remember. And other than multiple myeloma, it is also used as adjuvant therapy for different other other disease conditions. Okay, and a few bone marrow transplantation conditions, and in other conditions also it is used. But most commonly, Melphalan is used for multiple myeloma. Clear? Now you see. And one more important point: Melphalan is available in oral form and it is available in IV form. In oral form, the Melphalan bioavailability is not as good as other drugs. So oral tablets are less commonly used and IV is most commonly used. Okay, IV formulation of Melphalan is used in the hospitals commonly. Oral भी use करते हैं, but in few cases we use oral formulations. And when oral formulations were given, always we take precautions that this drug should not be taken along with food. Along with food, it should not be taken because it will interact with food, and it should not be taken along with other calcium supplements or many other drug food interactions it has, because it is not absorbed properly from GI tract, and in most cases Melphalan is suggested to be taken in empty stomach. This is important point. So to decrease all these precautions and all, better if the patient is hospitalized, we will go with IV form. Okay, so this is IV formulation, you can see. And yeah, it's let us discuss the mechanism of action of Melphalan. As it is a alkylating agent, same like other drugs. See, this Melphalan also goes and binds to the guanine of the DNA base pair. Okay, it goes and binds to the guanine and it causes alkylation. It alkylates the nitrogen base of the DNA molecule, and with that, what it does? It will form cross link. It will form cross link, and with this, it will stop the DNA replication. DNA replication will be stopped, and with that, neoplastic cells will be destroyed. This is common mechanism of action like other nitrogen mustards. Okay, so as it is also a alkylating agent, it has same mechanism like cyclophosphamide and ifosfamide and all. Okay, and one most important point you have to remember here: this drug has less cytotoxic property. Cytotoxic property, this is very important. Why it is having less cytotoxic property, and it has very less what we can say allergic reactions. See, in cyclophosphamide, what we have discussed, it will cause severe irritation and causes hemorrhagic cystitis, right? Hemorrhagic cystitis, and with that it causes inflammation. It is because it is having high cytotoxic ability. And here for Melphalan, it has no vesicant activity. Vesicant activity means here it will not cause pruritus, it will not cause any allergic reactions, it will not cause any pimple formation like that, because it is having less irritant action and it is less cytotoxic, like unlike other nitrogen mustards, cyclophosphamide and ifosfamide. Okay, this is important point you have to remember. Now you see, I was explaining you about multiple myeloma. Multiple myeloma. Melphalan is very, very effective for multiple myeloma, right? Now, let me add some important points to make you understand what multiple myeloma is. Okay, see, first point: multiple myeloma is the disorder or cancer of plasma cell. Plasma cell. It is the cancer of plasma cell. First point. And what do you know about plasma cell? What do you know about plasma cell? Anybody from the class, what do you know about plasma cell? Multiple myeloma is the cancer of plasma cell. In multiple myeloma, the plasma cell proliferation is very high, and with that, lot of non-functional or dysfunctioned plasma cells are synthesized in the body. That is multiple myeloma. Multiple myeloma is the cancer of plasma cell. Now, what is plasma cell? Who will tell? These plasma cells are obtained from B lymphocytes, right? These are obtained from B lymphocytes. Lymphocytes. Now, what is B lymphocyte? We have T lymphocyte, we have B lymphocyte. To make you understand, somewhere yeah. Now everybody should try to concentrate here. I will try to tell you what is plasma cell, what is T lymphocyte, what is B lymphocyte, and what exactly multiple myeloma is. Okay. Now you see, just imagine this is uh, a stem cell in the bone marrow. In the bone marrow, we have multipotent, pluripotent hematopoietic stem cell. Because from this single stem cell only, all other blood cells are synthesized. Okay. Initially, this stem cell will differentiate into two cells. In that, we have one myeloid cell and the second one is lymphoid cell. ध्यान से सुनना सब लोग. This is very very important in hemopoietic cancers. Again, these all concepts will come, but for today, try to remember all these things. First, from this stem cell in the bone marrow, okay, in the bone marrow, stem cell will differentiate into two cells. One is myeloid cell, and second one is, this is first myeloid cell, and second one is lymphoid cell. This myeloid cell will further differentiate into thrombocytes. Actually, megakaryocyte करके आता है. Mega thrombocyte. From this mega thrombocyte, all platelets will be synthesized. Thrombocytes are platelets. Plate platelets. And these platelets are important in forming coagulation cascade. Okay. So this, if platelet decreases in the body, that is called thrombocytopenia. Okay. So just because we have first year and second year student, just to make them understand, I am telling all these basic things. From the myeloid cell again differentiates into megakaryocyte. From megakaryocyte, thrombocytes will be formed. Thrombocytes are platelets. And again, this myeloid cell will differentiate into pre-erythroblast, and from there, erythrocytes will be obtained. Actually, here few steps are there. Finally, this myeloid cell will differentiate into erythrocyte. Erythrocyte is the RBC. Erythrocyte is RBC. These RBCs are very important in exchange of carbon dioxide and oxygen in the body. And this erythrocyte contains hemoglobin. Hemoglobin is the pigment. It contains iron and all. Okay, all these things we already know. If you are new with anemia and anemia concept, I have discussed about anemia, all concepts about anemia. We have 9 to 10 types of anemias. You can watch in our YouTube channel. Okay, we covered everything about anemia, different types of anemia and all. Anyway, see, myeloid cell is differentiated again into RBC, and it is also differentiated into mast cell. Mast cells will produce histamines. They will produce histamines, and these mast cells, histamines, are the inflammatory mediators. They will act like neurotransmitters. It is having many actions. Anyways, about these mast cells we'll discuss in another class. And again, it will also differentiate into myeloblast. This is very important. Myeloblast again further divides into different types of white blood cells. In that we have basophils, neutrophils, eosinophils, monocytes, and these monocytes again differentiate into macrophages. These are important in immune system. I mean, these macrophages are important in fighting with the bacteria. Okay, so these are different types of cells which are differentiated from the myeloid cell. And here the second one is lymphoid cell. This lymphoid cell will differentiate into two main cells, which is NK cell, which is also called natural killer cell. It is a type of immune cell. And second one, it is differentiated into lymphocyte. This lymphocyte further differentiates into T lymphocyte and B lymphocyte. This is very very important. Now you see, the lymphoid cell was differentiated into NK cell and lymphoid cell, right? This lymphoid cell will further differentiates into T lymphocyte and B lymphocyte. This T lymphocyte will show cell-mediated immunity. These T lymphocytes will show cell-mediated immunity, and these B lymphocytes will produce plasma cells, and these plasma cells will produce antibodies. We have IgG, IgM, IgA. Okay, we have Ig kappa, K, IgK. All these are different types of immunoglobulins. Immunoglobulins are antibodies. So the plasma cells which produces antibodies in the body, through these antibodies, it will cause humoral immunity. Okay, T lymphocytes are showing cell-mediated immunity. The example of cell-mediated immunity is if patient is having tuberculosis, TB infection. In that, cell-mediated immunity is seen. Rather than antibody production, cell-mediated immunity is seen in TB. And in few other infections, when antigens are entered into the blood or into the body, these plasma cells will be activated, and these plasma cells will produce a lot of immunoglobulins, antibodies, and they will neutralize the antigens which are contaminated in the body. Okay, so these are different types of cells which are differentiated from the single stem cell. Now you see here, plasma cell is the type of cell which is very important, which is actually differentiated from B lymphocyte, right? And this plasma cell, what it is doing, it is helping in production of immunoglobulins or antibodies, in short, in simple. So what we discussed Multiple myeloma is the cancer, or it is the disorder of plasma cells. These plasma cells are obtained from B lymphocytes. I think you got clarity with this simple differentiation chart. Okay. Now you see, let me tell you some other points. You understood what is plasma cell, from where this plasma cell has come. Okay. Now the simple definition of multiple myeloma is nothing but it is the cancer of plasma cell. When patient develops multiple myeloma, what happens? A lot of plasma cells, immature plasma cells, we can say, or neoplastic plasma cells, are produced in the body, and these neoplastic plasma cells are not normal. They are produced very rapidly. Their proliferation is very high. Their turnover is very high. So excess uncontrolled uncontrolled development of neoplastic cells is cancer. So here, excess uncontrolled development of neoplastic plasma cells is called multiple myeloma. Clear? Now, let me tell you some other concepts. Are you all following me? Everybody? Yes. Now, let me add few more basic points to make you understand. We understood what is multiple myeloma. Now, multiple myeloma is very, very commonly seen. It is commonly seen only in elders, and in elders particularly above 50 years of age. Very important point. Multiple myeloma छोटे बच्चे में नहीं दिखता है. It is prevalent especially in elders who are above 50 years. Very important point. Next point. See, I told excess production of plasma cells which are abnormal, or excess production of neoplastic plasma cells. When neoplastic plasma cells production is very high, that means these neoplastic plasma cells also produces excess amount of immunoglobulins. Yes, when plasma cells are produced in large quantity, plasma cells का function क्या है? To produce immunoglobulins. So here in this case also, the excess amount of neoplastic plasma cells produces more amount of immunoglobulins. Immunoglobulin concentration is very, very high in the body, but the immunoglobulins which are produced in the body are useless. They don't show any immune response in the body. These immunoglobulins which are produced, they should go and neutralize the antigens. They should go and fight with the antigen, and they should neutralize, and with that they should show, or they should decrease the infection or any other condition in the body. But these immunoglobulins which are synthesized by the neoplastic plasma cells are useless. Actually, immunoglobulin concentration is very high in the blood, but these immunoglobulins are not having any action. This is another important point you have to remember. Next, I would like to tell you the important clinical presentations. So let us see what clinical presentations in multiple myeloma. Okay, very, very important. This is clinical presentations means what lab parameters or abnormal lab parameters are seen in the patient, and what signs and symptoms are seen in the patient. All these are clinical presentations. Patient के body के अंदर signs and symptoms क्या है, and if we perform lab test, what abnormalities are found are seen in the lab test. All these will come under clinical presentations. Now, the first very, very important clinical presentation of multiple myeloma patient will have severe bone pain. severe bone pain. Very, very important clinical presentation. सबसे ज्यादा अगर किसी को मल्टीपल माइलोमा है, तो मेन क्लिनिकल प्रेजेंटेशन व्हाट विल बी सीन? Severe bone pain. Why multiple myeloma patient will have severe bone pain? Because in these multiple myeloma patients, the bone activity, or the what we can say osteoclast activity of bone, osteoclast activity of bone is very high. Now, again, we have to talk about osteoporosis and the mechanism of osteoclast. Already these concepts we have discussed in bisphosphonates and in the osteoporosis. Again, if you want to get clarity about all this, you can watch in our YouTube channel. You can search bisphosphonates. In that, clearly I explained the mechanism. In fast forward, you can learn. Anyways, you see, osteoclast activity, when osteoclast activity increases, simple, bone resorption increases. Bone resorption increases. Resorption means bone degradation. degradation increases. Resorption means यहाँ पे reabsorb नहीं होगा. Resorption means bone degradation. याद रख लो. Patient's main clinical presentation is patient will have severe bone pain, and that is due to the increased activity of osteoclast, and osteoclast activity, when it is increased, it will try to destroy the bones. Clear? And here, in severe bone pains, particularly the osteoclast bone resorption is seen especially in vertebrae. Very, very important. Initially, it will start with vertebrae, and it is very commonly seen in vertebrae. So, due to bone resorption in vertebrae, patient will have severe backache, severe back pain. In multiple myeloma, patient will have severe bone pain, and that is, patient will have severe back pain because vertebrae bones are having degradation. Number one, and again, along with vertebrae, few patients also has bone resorption in ribs. So, patient will have pain in the thorax region. Due to less density of ribs, patient will have pain in the thorax region. This is another very important clinical presentation with which are associated with bones. So, okay, patient will have severe bone pain. I think you understood this very important point. This is first important clinical presentation. Next, very, very important clinical presentation. Patient will have hypercalcemia. Elevated amount of calcium in the serum is called hypercalcemia. Hypercalcemia. The normal calcium level is 9 to 11 mg per dl. The normal serum concentration of calcium is 9 to 11. If calcium level is less than 9 mg per dl, that is hypocalcemia. And if calcium level is greater than 11 mg per dl, that is hypercalcemia. So in multiple myeloma patient will have hypercalcemia. Why patient will have hypercalcemia? Because the calcium which is, yes, the calcium which is present in the bones is degraded, and from there the total calcium or the calcium is removed, and it is brought to the blood, it is brought to the plasma. Because of that, excess calcium is seen in the serum. So hypercalcemia is the second important clinical presentation in the multiple myeloma. And now you see, because of hypercalcemia, patient will have to face very important lethal consequences. So in hypercalcemia, what happens? In hypercalcemia, the excess amount of calcium will try to excrete from the kidneys. The excess amount of calcium which is present in serum. अगर serum के अंदर अगर calcium ज़्यादा है, तो the excess calcium in the serum has to go back to the bones, and it should be absorbed into the bones, and the bone density should increase. And this action is performed by vitamin D. In bisphosphonates, I explained all the mechanisms. The serum calcium which is present in the blood or the plasma calcium, excess calcium should enter into the bones, and it should increase the bone density, or the excess calcium should be excreted from the kidneys. It should be excreted from the kidneys. These two are normal physiologies in hypercalcemia. But here, due to increased bone degradation, due to bone resorption, the calcium is not entering into the bones, but it is coming from the bones. So next option what we have, to decrease the calcium in the serum, our body tries to remove the calcium from the kidneys. So it will cause calciuria, calciuria. The excess amount of calcium will be seen in urine. So due to hypercalcemia in the serum, again if you check the patient's urine, in urine you will find lot of calcium levels. So excess calciuria is another clinical presentation for multiple myeloma. And you see, if this same condition keeps on prolonging, if this condition keeps on increasing, slowly what will happen? The calcium, excess calcium, will try to accumulate in the kidneys, and it will cause CKD. Very, very, very important complication of multiple myeloma. Important complication of multiple myeloma is it will cause chronic kidney disease due to calcium is accumulated in certain tubules. Okay, because the calcium should be excreted from the tubules. If the calcium concentration is accumulating in the tubule, what it does, it will damage the nephrons, or it will damage the tubules, and with that it will cause, slowly it will lead to chronic kidney disease. So CKD is one important complication of multiple myeloma. Here I told you one point. See, due to hypercalcemia, patient will have kidney injury, and along with that patient, actually this hypercalcemia will try to induce diuresis. So along with this patient will have polyuria also. Polyuria. Excess calcium in the serum also induces polyuria. This is another important point. And here you have to concentrate. Everybody should try to concentrate. There is one concept called nephrogenic nephrogenic diabetes insipidus. How many of you heard about nephrogenic diabetes insipidus? Everybody knows diabetes mellitus. Diabetes mellitus is characterized by increased glucose in the blood, and with that it may cause diuresis or it may cause glycosuria. But here in nephrogenic diabetes insipidus, the patient is mainly characterized by polyuria. But here in polyuria, there is no glycosuria, there is no glucose present. Patient will have polyuria, but patient will not have uh, uh, glucose in the urine. And that condition which is associated with polyuria is called nephrogenic diabetes insipidus. And this nephrogenic diabetes insipidus is mainly due to hypercalcemia in the serum and due to calciuria. And here in this condition, actually diabetes insipidus is the condition which is mainly seen due to absence of vasopressin. Actually, vasopressin is the antidiuretic hormone. Let me, I think, यहाँ पे, yes, diabetes insipidus is the condition which is seen due to deficiency or due to inappropriate action of antidiuretic hormone. Actually, you see, this antidiuretic hormone will go and bind on the tubules and it will try to reabsorb the water. It will try to reabsorb the water from the kidneys. It will reabsorb water and it will decrease urination, right? But in few cases, the antidiuretic hormone synthesis is totally stopped. Okay, in that condition, we call it deficiency of antidiuretic hormone. Or in few cases, antidiuretic hormone is already present, but the action of this antidiuretic hormone is not properly seen in the kidneys. In kidneys, this antidiuretic hormone will go and it will try to bind on the nephron, but it will not show action. It will not show action. This condition is mainly associated with the accumulation of calcium in the urine, calcium in the kidneys. Due to accumulation of calcium in the kidneys, due to calciuria and due to hypercalcemia, it is decreasing the activity of antidiuretic hormone, and with that, patient will have polyuria, or patient will have nephrogenic diabetes insipidus. Remember, everybody, multiple myeloma is associated with hypercalcemia. This hypercalcemia got accumulated in the kidneys, and with that, it decreased the activity of ADH, and with that, it caused nephrogenic diabetes insipidus. And with this, patient developed polyuria. Polyuria. So polyuria is the another very important clinical presentation of multiple myeloma. Multiple myeloma patient में बार बार urination को जाते रहता है. Multiple myeloma में patient बार बार urination को जाते रहता है. This is another important clinical presentation. I think everybody are trying to follow me. Okay. Now you see, और बहुत सारे concepts हैं, very very important concepts we have. Actually, today I talked with Dr. Ravi. He is a hemato-oncologist. I asked him few cases to present, but he was busy, so I'll try to arrange the session soon. Okay. Now see another important clinical presentation. See, I told multiple myeloma is the condition where excess amount of neoplastic plasma cells were increased, right? Excess amount of plasma cells are produced in the body. Now, when excess amount of plasma cells are produced, again, excess amount of immunoglobulins are synthesized in the body. That also we have discussed, right? Now you see the main clinically, if we check the patient, especially immunoglobulin G, IgG बोलते हैं. IgG concentration is approximately, or it is less than, it is more than or equal to 60%. If IgG concentration is greater than or equal to 60%, then in that conditions we can suspect multiple myeloma. So in multiple myeloma, IgG concentration is 60%, and the other remaining immunoglobulins, like we have IgA, it is having 20% concentration, and we have Ig kappa. This is important. IgK bolte. This is another. It is having 20%. So especially IgG concentration is very high in multiple myeloma. This is important clinical presentation you have to remember. Now you see, as I told, increased amount of immunoglobulins in the plasma. This is important. In the plasma, excess amount of immunoglobulins are seen. This excess amount of immunoglobulins will cause one condition which is called hyperviscosity syndrome. Hyperviscosity syndrome. Hyperviscosity syndrome is nothing but it is the condition which is mainly characterized by excess amount of immunoglobulins in the serum. Clear? Excess amount of immunoglobulins. If you check the blood, in the blood, total blood के अंदर पूरा immunoglobulins ही रहता, and this excess amount of immunoglobulins will try to accumulate in the skin. It will try to accumulate in the eyes, and when it is accumulating in the eyes, what it does, it will cause blurred vision. Blurred vision. Very very important. Another clinical presentation. In multiple myeloma, we can see due to excess amount of immunoglobulins in the plasma, what it goes and accumulates in certain tissues, especially in the eyes, and it causes blurred vision. Another important clinical presentation. So, hyperviscosity syndrome, I think I have added somewhere here. Let me try to show you the image. Yeah, try to see this. This is the image which talks about uh, hyperviscosity syndrome. See, this is the plasma. In this plasma, excess amount of plasma cells are seen, and this excess amount of plasma cells are producing a lot of immunoglobulins. The yellow color one, the yellowish color one, you can see IgG, and remaining the white color immunoglobulins, you can estimate them as IgA. So due to the excess amount of plasma cells and excess amount of these immunoglobulins, the plasma becomes hyperosmolar, or sorry, hyperviscous. So due to increased viscosity, it causes one condition which is called hyperviscosity syndrome. Understood, everybody? Clear? Are you all following? Are you all following? Yes. Now you see, very good. Now, another important clinical presentations, as I told you, due to elevated amount of immunoglobulins, these, despite these immunoglobulins are high, these immunoglobulins are non-functional, right? Or these immunoglobulins are, they are useless. They are useless. So when immunoglobulins are useless, patient will go to, patient will have high risk of infections. Yes or no? When the immunoglobulins which are produced in the body, if they are not functional, if they are not useful, patient will be experiencing a lot of contamination. Always we will be experiencing viral infection. Hospital we will be interacting with viral patients, we'll be interacting with TB patients, we'll interact with pneumonia patients. Okay, so we are exposing directly with the patients. So in that cases, as we are, immunoglobulins are well enough, they are sufficient enough, so they are functional and they are fighting with these infections. And with that, what happens, not actually TB, immunoglobulins will cause antigen antibody reactions. Actually in TB, cell mediated immunity is seen. We should not take TB as example here. Anyway, see, so in multiple myeloma patient, despite of high concentration of immunoglobulins, these immunoglobulins will cause infection. So patient will have high risk of developing, especially in females, patient will have urinary tract infections. Very, very important point. In multiple myeloma in females, patient will have high risk of causing urinary tract infections. And patient will have risk of fungal infections. Patient will have pneumonia. So if anybody is suffering with multiple myeloma, we should never allow them to, or we should never take them to high infectious prone zone. If those patients are taken to infectious zones, they may attack with UTI, or they may cause fungal infection, or they may cause pneumonia, community, hospital acquired, community acquired, anything it may be possible. Okay. So in females especially, it will cause urinary tract infection. One very important point you have to remember: multiple myeloma can be prevented, but it can't be cured. So since it is not cured, patient will be developing all this infection risk. So patient will be developing recurrent UTI. Yes or no? So if patient is having recurrent UTI, in UTI, I explained one point while explaining about urinary tract infections. Again, urinary tract infection video is available in my channel. You can see one very important complication for recurrent UTI is chronic kidney disease. So this is the second complication or second cause in the multiple myeloma. Multiple myeloma is having risk of CKD, and this is because of recurrent UTI, another, and this UTI is because of risk of infections. Just try to correlate with the all the concepts. I am just trying to correlate with all the concepts. Multiple myeloma में CKD हो सकता है, क्यों हो सकता है? Because infection की वजह से हो सकता है. It may be possible due to calcium also. Okay. Anyways, चलो, you understood about this infection clinical presentation, right? Now another very very important clinical presentation is it can cause anemia. It can cause anemia. And there is very important concept which is called triad of. This is very important in competitive exams. Triad of multiple myeloma. There is one concept called triad of multiple myeloma. There is one concept called triad of virtues triad. Virtues triad. In previous classes, I explained about different types of triads in different conditions. I don't remember in which class I explained all these triads. Okay, so here is the triad of multiple myeloma. Actually, this triad has three main clinical presentations. If patient has multiple myeloma, the multiple myeloma will be memorized or recognized based on this triad only. So in that, the first in triad of multiple myeloma, first one is it will cause, I mean it will show excess amount of plasma cells in the blood. And in that, actually, if we see, the excess amount of plasma cells are greater than 10%, especially in the bone marrow. This is first triad. In triad of multiple myeloma, the first one is greater than 10% of plasma cells are seen in the bone marrow. If these more than 10% of plasma cells are seen in the bone marrow, that gives one uh, 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 probability for multiple myeloma. Okay, this is one confirmatory test. Second triad, in second one, patient will have lytic bone lesions. Lytic bone lesions. I told one point, multiple myeloma patient is having risk of bone destruction or bone resorption, right? So if bones are seen in the X-ray, in X-ray, bone lesions are seen. Actually, if you see the X-ray of the bones like this, X-ray of the bones, in the bones we can see the lesions. Some few lesions are seen. Lesions means here the density of the bone is decreased. Light color is seen, and not light color. Here dark colored substances are seen, which indicates that bone density is very less in these areas. Okay, so these are the lesions which are called lytic lesions. Bone is broken down, bone is lysing here. Lytic means bone breakdown. So lytic bone lesions are seen in the X-ray. That is second triad in the diagnostic test of multiple myeloma. And third very important triad is it will have M component. M component means simple. Excess amount of immunoglobulins are seen in plasma. First triad, excess amount of plasma cells are seen in bone marrow. In bone marrow, especially greater than 10% plasma cells are seen. That is first trait. Second trait, lytic bone lesions are seen in the X-rays. And third, M component is seen. That is, patient's plasma is increased with immunoglobulins. Immunoglobulin concentration is very high in the plasma. That is third trait. I think somewhere here I kept. This is the multiple myeloma trait. Multiple myeloma trait. In that, first one is accumulation of plasma cells in the bone marrow. That is greater than 10%. Greater than 10% of plasma cells are available in the bone marrow. That is one. And bone lesions are seen. Bone lesions are seen, and here I think you can see the bone lesions. Is it clearly visible to you all? You can zoom and you can see. These are the bone lesions in multiple myeloma. These are called lytic bone lesions. Okay, and third one is more amount of immunoglobulins are seen in the serum, because it is main clinical presentation. Excess amount of immunoglobulins are seen in the serum. Clear? So these are three very important triads of it is a triad of multiple myeloma. With these three, you can directly diagnose that patient may have multiple myeloma. Clear, everybody? This triad understood? These are very important clinical points. When you go to hospital, these all points you can directly see. You see, our concept is related to oncology, so I am going in detail about the diseases. I'll try to go in detail. So, anyways, apna abhi Melphalan is there. So Melphalan is used only in multiple myeloma. That's why I'm trying to discuss about this condition in detail. Okay. Now you see, Abhi, we will go back to uh, the drug. Before that, I will try to tell you one important point. See, finally, we understood what is multiple myeloma and the clinical presentations we have discussed and how it is diagnosed. We have discussed in diagnostic test. See, if you see, actually, the more clear confirmatory test bolte or diagnostic test bolte, we call it confirmatory test. For confirmatory test in multiple myeloma, we have one test called bone marrow examination. Bone marrow examination. And in bone marrow examination, if CD 138, there are some certain cells called CD138. If CD138 cells are positive, if CD138 cells are positive, we can say that patient is having bone marrow, patient is having multiple myeloma. This is one. And along with this, if patient has the what we say the triad of multiple myeloma. If patient has these two are confirmatory tests. With this test, we can diagnose that patient is having multiple myeloma. And after diagnosis, actually, you see, for multiple myeloma, we have main treatment. We have main drug. Very, very important drug here is we have Melphalan. Melphalan is the alkylating agent in the nitrogen mustards. Okay, in nitrogen mustards, alkylating agent. This is Melphalan is one drug, and along with this, we can also use very, very important drug, that is dexamethasone. Dexamethasone. Very, very important corticosteroid. Corticosteroid. See, again, I'm telling corticosteroids are very, very important drugs. In one of the online lectures, I see in playlist, if you go and check, I have so many online classes. In that, you will find the corticosteroids lecture. So in corticosteroids, I explained everything in detail, its adverse effects, its doses, their classification and all. So among corticosteroids, dexamethasone is one of the corticosteroid, which is a long-acting corticosteroid. Okay. And these corticosteroids are having many adverse effects. That all points already I discussed. Now this is not good time to discuss all these things. Okay. So the second very important drug for multiple myeloma is dexamethasone, which is a corticosteroid. And third important drug, there is one very, very important surprising drug is and that is thalidomide. Thalidomide. I think most of you know about thalidomide. Other than first second year students, everybody might know about thalidomide disaster. Thalidomide के बारे में सबको पता है. How many of you don't know about thalidomide? Raise your hand, please. I think everybody knows. Okay, very good. See, actually, this thalidomide was initially, yeah, someone raised a hand. Yeah, these are first year students. About this thalidomide, one day I'll try to explain for all first year students. I will try to explain about this, but now it's not the time. Okay. Anyways, chalo. Actually, this thalidomide was used in 1960s and in 1950s. 1950 May, 1960 May, this drug was mainly used for morning sickness. Actually, morning sickness is the condition which is mainly seen in the pregnant ladies, which is characterized by headache, nausea, vomiting. ये सब होता है. Early pregnancy में ये सब होता है, which is called morning sickness. So in morning sickness, there was the effective drug in those days in 1960s and 50s. This thalidomide was used very commonly, and when this thalidomide was used in these pregnant ladies, it caused very, very important adverse effect, which is called hocomelia. Hocomelia. Actually, after birth, the patients, the neonates were born without limbs, without hands and legs and without limbs. ऐसा पैदा हुए. So that condition is called. वो time पे ऐसा हुआ था. There are thousands of women have taken this drug and they got that condition, and that condition in those days was regarded as thalidomide disaster. Okay, so in those days it was banned. Immediately it was banned. Thalidomide is causing high teratogenic activity, so that's why it was banned. But now in now today they are using this thalidomide for multiple myeloma. Actually, देखो, all antineoplastic drugs are very, very dangerous for pregnancy. In pregnancy, none of the antineoplastic drugs should be used. वो already पता है. In those days, without proper clinical trials and all, थोड़ा politics चला, and वहाँ पे what they did, they, without checking properly, they approved the market. Because of that, it has adverse drug reactions. But nowadays, what this drug has proven is this drug is very, very effectively used for multiple myeloma. It is also used for leprosy. You know, leprosy. It is used for leprosy. Nowadays, it is used for leprosy. If anybody is trying to write one review article, you can write one article. Effectiveness of thalidomide on leprosy. You can write one article. There are so many researches which are published on thalidomide and its efficacy on leprosy. You can write in your research. If you find that thalidomide is very effective for leprosy, you can publish that paper. Just try to collect the information, and you can take my help in normal time. You can text me. I will try to help you how to write the article and how to publish it. I will help in that. Okay. And few other students are also there in the group, like Shrestha Sumaya is there, Prajwal is there, Shivani is there, and few fourth year students is there. Vedic Gautam is there. You can talk to them also. They will also help you how to write article, because they are working on different articles. They are I'm guiding them. Okay. Anyways, chalo. So you can write this article. This is the third very important drug that is used in multiple myeloma. And there is one more drug, one more. Actually, this thalidomide is the newer regimen which is used along with melphalan in multiple myeloma. पुराने जमाने में देते थे नहीं. Now we are using thalidomide is added in this regimen, okay, for multiple myeloma. And the fourth important drug what we have is bortezomib. 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 Okay, so this is another important drug that is included in treatment of multiple myeloma. So in multiple myeloma, what we have treatment, actually these all drugs can be used. Few conditions these drugs are used in combination, and in few conditions they are used alone. Okay, so melphalan, dexamethasone, thalidomide, and bortezomib. So these are different drugs. Actually, this bortezomib, this drug actually it what it does, this drug will go and inhibit the uh, protozomes protozomes in actually there are some enzymes called proteosomes. There are some proteosomes. For example, this is, imagine this is a cell. In cell we have some enzymes which are called proteosomes. These proteosomes are important in breakdown of certain proteins, and they help in the formation of new proteins, and with that it helps in the cell proliferation. Okay, so these proteosomes are helpful in cell proliferation. So this bortezomib, what it does, it will go and inhibit the enzymes proteosomes in these neoplastic cells of plasma cells, and with that what it does, it will decrease the proliferation and it will kill the neoplastic cell. It is having that action in the body. Okay, so that is about bortezomib. Now let's go back to the pharmacology of melphalan. Melphalan pharmacology is very important. Now let us discuss. I think you all understood the basic points about multiple myeloma, the clinical presentations of multiple important points only I discussed. Okay, in hospital wo kafi hai. We are not expertized in diagnosis and all. It is not necessary for us. Okay, now you see. Yeah, a few points, mechanism, pill mechanism we have discussed. Now let's discuss the kinetics. See, melphalan is, as I told you, it is available in oral form as well as IV form. When it is given through oral form, it is not properly absorbed from the GI tract. That point already we know. That's why it is most commonly used in IV. Okay, and here very important point you have to remember: 10 to 15% of melphalan is excreted unchanged from the kidneys. So, if anybody has CKD or if anybody has kidney impairment, in those cases, the toxicity of melphalan can be seen. Melphalan concentration may be increased, and with this it may cause more myelosuppression. Myelosuppression, this is important point you have to remember. So if anybody has chronic kidney disease or kidney impairment, in that cases 10 to 15% of the drug dose should be decreased. अब यहाँ पे if we are giving 2 mg, and if this 2 mg is given 3 times a day, what we do, we will try to go with 2 times a day, because this melphalan's t half is approximately 50 to 60 minutes. So if its t half is approximately 50 to 60 minutes, its duration will be around, its duration of action will be around 6 to 8 hours per day. Okay, so approximately twice or thrice daily can be used. Okay, melphalan tablets, if 2 mg is given, 3 times a day can be given, or 2 times a day can be given. So based on the frequency and all, we can try to decrease the dose. So 10 to 15% of, because 10 to 15% is directly excreted in unchanged form. That's why I'm telling. Okay, you understood? I think you understood this important kinetic point. Now, if you see the treatment guidelines with melphalan, here, as I told you, melphalan is very commonly used for multiple myeloma, and it is administered 4 to 7 days. Okay, it is administered for total 1 week, and it is stopped. And this total 1 week is given for every 28 days. 28 days में एक बार. 28 days में एक बार. We have to go with that. If this melphalan is used continuously for 1 month, what will happen? It may cause myelosuppression, and with that it causes pancytopenia, and again that condition again causes the condition will be worsened, and it will again cause so many other disorders. Okay, so what guideline is telling, melphalan 2 mg tablets should be used twice or thrice daily, and that is used for 4 to 7 days, and this strategy is followed for every 28 days, and this melphalan is used at, along with dexamethasone or thalidomide. It may be mixed with dexamethasone or thalidomide and or bortezomib. It can be used. Okay, melphalan is main. Melphalan can be used. Melphalan plus dexa or thalidomide. Plus we can go with bortezomib. Actually, this bortezomib has different mechanism of action. That's why it will show synergistic action. So this is the treatment strategy we follow with melphalan in multiple myeloma. And see, as we have other alkylating agents, actually other alkylating agents like ifosfamide, cyclophosphamide, and other drugs, they were having many other adverse effects, right? So this drug, nausea and vomiting, is its frequency is less when compared with the other drugs, and it causes less alopecia, and rarely it may cause renal and hepatic dysfunction. So these are important adverse effects you have to remember. When we compare this drug with cyclophosphamide and ifosfamide, it is quite safer drug because it has very less general toxicities. See, in previous class I told about the general adverse effects or general toxicities of cyclophosphamide, right? This Melphalan has less general toxicities or general adverse effects, you can say. Okay, so this is important point you have to remember about Melphalan. और कुछ बचा है इसमें Melphalan के बारे में? Multiple myeloma discussed. So discussed. Yeah. So to diagnose the plasma cell multiple myeloma, we can see the normal cells. Actually, these plasma cells are seen in the microscope. When we see in the microscope, dense plasma cells with dark colored. Actually, यहाँ पे बहुत सारे parameters we have for diagnostic purpose. It is not important for us because we are not diagnostic specialists. We are not pathologists, no. So just imagine one thing: when we check the normal cell and the multiple myeloma cell of the plasma cell, here in normal cell the density of the color is less, and here the color density is very high. I mean the color intensity is very high. That's it. And more amount of plasma cells can be seen. That blood count में तो easily पता चली जाएगा. Okay. So this is important point you have to remember. I think about chlorambucil and about lymphocytic leukemia के बारे में we'll try to discuss tomorrow. Be